I actually don't understand still why I'm recording, and maybe today is the last day of this one. That's why. Hmm. Very confusing, this recording and not recording. Really, I am confused because what happening now when the participant I am receiving. I will tell you one secret also. I don't know how the background this one the background of participant with their, even they have closed their mic. I can receive the recordings in which I can hear what they are hearing during the class. I don't know what type of setting in this Zoom meeting is. So I have maybe 9 recordings of candidates also. So it's very difficult from those recordings. I still unable to understand how the participant recordings are coming in this one. Maybe when they are after the time of the class, when they are clicking on the link and then they are entering the class, and by default there is ongoing recording, maybe 10 p.m they are opening at middle of the night, and by somehow 3 to 4 seconds they have recording themselves. I don't know what is this confusion really. I, anyhow, I am still learning. I am able to record some lectures, and I will see what is the problem. Okay, I will start. uh, the management of tubal ectopic pregnancy. Now this is very important. And in the real life scenario also, I will tell you the real life scenario also what to do. Give all women with an ectopic pregnancy written information, oral information, that what to expect during and after treatment. Really you will not understand because I am practicing here. Here the protocol is, when you are giving the ectopic pregnancy medical management, you have to keep them for 7 days, and you don't know how I am dealing with them for 7 days when the patient I have given the injection. Now this nice guideline, they tell that they are not admitting the patient medical management, and they are sending the patient with complete communication. They are explaining each and everything, when to return to back to the hospital. So that means after medical treatment you don't need to admit the patient. So because here in the Saudi Arabia, you cannot let the patient go home after medical because patients are not so well educated. And here the system, they are very rich. They can keep the patient for 2 weeks, 1 month, when whatever days they want to stay in the hospital. Okay, so but also there is a hospital policy. You give the medical management and you keep the patient for 1 week with you. This is our hospital policy. But in NHS, in this new NICE guideline, which they are actually following the NICE guideline, they are not following the green top guideline. For their hospital managements, they are following the NICE guideline. Please, guys, they are following the NICE guideline, not following the green top guideline. Green top guidelines are coming after NICE guideline. So they are not admitting the patient for medical treatment. Okay, so you have to explain the patient written and oral information, that what treatment, what to expect during and after treatment, when they have to contact the health professional for advice after treatment if needed, and who this will be, and where and when to get help in emergency, because after injection they are sending back patient to home. So inform women who have an ectopic pregnancy that they can self-refer to any early pregnancy assessment service in future pregnancy if they have any concern. So here again, any patient who have molar pregnancy, previous ectopic pregnancy, or recurrent pregnancy loss, they can self-refer themselves to early pregnancy assessment unit without being needed to be referred to by GP or midwife or nurse. They can self-refer them. They can go to the early pregnancy assessment unit and they can say that we have this high risk history. Expectant management. Okay, so offer expectant management as an option to women who are clinically stable, pain-free, have tubal ectopic pregnancy less than 35 mm with no fetal heartbeat on TVS, and serum fetal HCG of 1000 or less, and are able to return for follow-up. Okay, here please listen. Here 1000 you have to offer. Okay, and between 1000 to 1500 you can consider expectant management, but 1000 or less than 1000 you offer. Okay, and they have to offer for they are able to return for follow-up. So if the patient is expectant management, you have to repeat beta HCG on day 2, 4, and 7 after the original test. Believe you me, I read this guideline 2 times. And then the third time I understand they are offering day 2 beta HCG only for expectant management, not for the medical management. So expectant management, they are repeating the beta HCG for day 2, for day 4, and for day 7. Why they are repeating after day 2? Because they are afraid, because they are not giving the patient injection, and maybe they have giving the injection, not maybe the patient beta HCG is between 1000 and 1500, and they don't want to miss the opportunity. If it is rapidly progressing beta HCG, maybe they will reconsider the option of expectant management. That's why I think they have added this after 48 hours beta HCG, so to see what's going on. You decided it's a confirmed diagnosis. Now you repeat after 48 hours, and you want to see what is going on. Is still she's having still the candidate for expected management or no? So that's why they are doing this 2, 4, and 7 after the original test. And here, if beta HCG drop by 15% or more from the previous value on the days 2, 4, and 7. Now here, what my understanding is that you can tell your understanding, because this is by grammar. What I understand that beta HCG decreases from day 1 to day, yani after 48 hours, it decreases 15%, and then day 2 to 4 also 15%, and 4 to 7 after 15%. This is my understanding. Or as you wish, but they write like this: it drops by 15% or more from the previous value on days 2, 4, and 7. So then repeat after it become 15%, 15%, 50%. Then you repeat weekly, because if you remember previously they said in pregnancy of unknown location, if beta HCG decreases or after 48 hours, if it decreases more than 50%, then this is a good news. Okay, then how come it is 15% on only yani between 1 and 7 days? I think for every day when you are doing on day 2 15%, then 2 to 4 15%, or more than 15%, or day 4 or 7 more than 15%, then you can relax, and you think that okay, expected management is working, and you repeat weekly until a negative test less than 20 international unit is obtained. I think this is what they are trying to do here. If beta HCG do not fall by 15%, okay, stay the same or rise from the previous value. Okay, in the exam, actually the pictures are now coming. Now they are become more and more modernized. They are giving the pictures. They are giving the pictures in their charts, and in which the beta HCG the graph is rising, and then it is showing that it is become plateau. It's not either decreasing, it's not either rising. It's almost coming same. So if it is showing that type of grass, that means it stays the same plateau. Or if it is not falling down 15%, very little fall, or if it is rising from the previous value, then you have to review and you have to take senior advice. Maybe they will give you in the exam, this is the patient, she has a confirmed ectopic pregnancy. You select her for expectant management, and this is her day 2, 4, and 7 chart. And what is your further management? That's it. You will see the chart and you will forget, oh, this is written in the guideline that what I have to do. Don't confuse yourself. They will give the chart, and now you have to see. You will select in the EMQ. You will review the woman clinical condition, and maybe you want to see senior advice. Okay, so search for these options: review or search for the senior advice, because you are ST5 and you need ST6 or ST7 advice, because usually ST6 and ST7, they are doing gynae emergencies and gynae you are also doing gynae emergency, but I think in these cases maybe ST6 and 7, the role of ST6 and 7 is coming, so you need to take senior advice. So expectant management, what you said, you have to tell the patient, please, either you take medical management and either you take medical management. because I have these two types of crazy women. One patient, I was trying to give her injection. She was a nurse and she was saying, no, I will not take medical treatment. I want expectant management. I was very surprised. Okay. And she was asking me these questions. She's saying, will it increases my chance of rupture ectopic, or will increase my chance of future pregnancy being recurrent ectopic? And she's asking me all those questions. And literally, I don't have answers. Now, I don't exactly, if I will not give, it will affect her anyway. So actually the answer is here. There is no difference between expectant and medical management. And the rate of ectopic pregnancy, either you give medical or expectant, it will end naturally. The risk of tubal rupture, she was asking me if I will take medical management, my tube will rupture. I was unable to tell her. I said, no, if you will take expectant management, maybe there is more chance of tube rupture. I literally telling her like that. So but she didn't, and she wins. She go for expectant and she wins, and she was clear pregnancy test after 3 weeks. So I have to tell her, no, the chances of tube rupture, because if you are willing patient, the chances of tube ruptures are same, either expectant or the medical. So it's up to you. So the need for additional treatment, but they may not be admitted urgently if condition deteriorates. So I have one patient, I give her medical management, and after 2 weeks, I was happy, her beta HCG falling. But still, after 2 weeks, there is a risk of rupture ectopic pregnancy 15%. There is still risk after 2 weeks, still risk. And after 2 weeks, when I was very happy, she come with shock. After 2 weeks, her ectopic rupture. Okay, so we have to tell her still there is a chance 15% that, or whenever you have this condition deteriorated, you have to come to the hospital. And also definitely is a pregnancy loss, and it's same like you have lost your child, so you have to yani health status, depression, anxiety store, you have to assess the clinical condition. And the time taken for ectopic pregnancy to resolve and future fertility outcomes are likely to be the same with either expectant or medical management. So you have to tell the patient there is no difference in future fertility outcome, or whatever the question she was asking, the answers all are here in front of me now. So I can easily tell that no effect on the future fertility, no effect on the recurrence, no effect on the rupture ectopic, and there is no effect that there is a natural course of ectopic pregnancy will change with either treatment. Medical management you will offer which have no pain, and she has unruptured ectopic pregnancy with an adnexal mass smaller than 35 with no visible heartbeat and the beta HCG less than 1500. Okay, so they don't have intrauterine pregnancy, and they can able to return for follow-up. Please here see, they are not admitting the patient, so she should be able to return for a follow-up. If after injection she said, I cannot return back to the hospital, I am working woman, I cannot find off from my office or some scenario like that, and you have to offer her no. So if this is the case, you are not the candidate for medical management, you have to offer surgical management, laparoscopy. You have to tell the patient, and maybe they will give you a lawyer, very busy lawyer. She came to you and she said you diagnose her ectopic pregnancy, and now she's in hurry because she want to end this pregnancy as soon as possible. And maybe this is unplanned pregnancy, and now they will give you the scenario, this is her unplanned pregnancy and she's very busy, or she's a student, maybe she's a student, university student, and now she come to you for option. So maybe in this case, even if beta HCG is 1500 or something, still she's a criteria for medical, but in her scenario, social reason, you will offer her surgical management. So no option is absolute, right? So methotrexate should only be offered it should only be offered for first visit when there is a definite diagnosis of ectopic pregnancy, and intrauterine pregnancy you exclude. Offer surgery when treatment with methotrexate is not acceptable to the woman. This I already discussed. And women who choose methotrexate, the chance of needing further intervention is increased, and they may need to urgently admit if their condition deteriorates. Okay, so women with ectopic pregnancy who have methotrexate, you have to take 2 serum beta HCGs day 4 and day 7. after treatment, and then serum beta HCG per week weekly until the pregnancy test negative is obtained. If beta HCG levels is plateau or rising, increases the woman condition, reassess the woman condition for further treatment. The same thing here in expectant management, you will do day 2, day 4, and day 7, and you will after day 7 then you will do weekly, right? Here you will do day you will take beta HCG on this one, and then you will do day 4 and then day 7, and then you will do again weekly beta HCG, right? So after weekly you will see what is the situation, because within 2 weeks still there is a chance of rupture 15 weeks. So at least after medical management you will do weekly, and again in the expectant management you will do weekly. Medical or surgical treatment. So which patient medical, which patient surgical? So if the patient you offer medical or surgical, if they have beta HCG at least 1500 but less than 5000, so between 15 to 5000 you can offer them surgical if they are unable to return for follow-up. Okay, because less than 1500, if patient don't want medical or surgical both, even you can consider them expectant management. But here if the patient have no pain and unruptured, less than 35, no intrauterine pregnancy confirm or ultrasound, so 1500 and 5000, patient is unable to return follow-up, you offer them surgical, otherwise medical. Surgical management, if any one, only one criteria is present, you will offer them surgical. Okay. First line management for one, I already discussed. If it is between 1500 to 5000, patient is unable to return for follow-up, methotrexate surgical, right? This is finished already. Now, if in this charts, any single thing is present, surgical, no other option. Ectopic pregnancy and significant pain. Any pain, surgical. Ectopic pregnancy, adnexal mass greater than 35 or larger, 35 or larger, or less than 35 for medical. So 35 or larger, surgical. Ectopic pregnancy with a fetal heartbeat visible, surgical. Ectopic pregnancy, beta HCG 5000 or more, surgical. And you already we discussed this one, that we will offer either surgical or this one. If they don't have pain already, I think we discussed this one, either surgical or either medical. So laparoscopy, you will offer laparoscopy whenever possible, because depend on the condition of the woman, taking the complexity of the surgical procedure. I will tell you one thing before what we know in our guidelines, that if patient is hemodynamically very unstable, that patient is in shock, maybe 50 by 30 blood pressure, and she has severe tachycardia. So it's up to, in a hemodynamically unstable patient, they are not doing laparoscopically. Okay, this is what my understanding. But in this NICE guideline, they didn't mention anything like that. They said it should be performed laparoscopy whenever possible. That's mean whenever possible mean whenever patient is hemodynamically stable and she don't have previous surgeries, previous 4, previous 5, not have multiple, not have midline scar, when it is technically feasible also. So you have to take in account the condition of the woman and complexity of the surgical procedure. So don't take it 100%. Just think of other scenarios also. If it is feasible, okay, do for laparoscopy. But if patient is very hemodynamically unstable, you need to open as fast as possible. So laparotomy is, I think, more faster when hemodynamically unstable, and also anesthetists don't want to give anesthesia for like, because when you do this filling, intra-abdominal filling of carbon dioxide, the blood pressure also fall down. So in this situation, the anesthetist will also not agree for laparoscopy, right? So salpingectomy or salpingotomy. Okay. So when you read the guideline, oh, it's very easy. Salpingectomy if other tube is healthy, and salpingotomy if other tube is unhealthy. But in actual exam, the scenarios are coming like that. The patient have left bleeding tube, which is and the pain of the left side, and there is a left adnexal mass, and the right tube, she has endometriosis, and there is in the pelvis there is endometriosis, and there is adhesions, and the right tube is looking healthy. Now in this scenario, they actually confuse you, that they have said to you that left side she has ectopic pregnancy, okay, which is the cause of bleeding, and on the right side now she has endometriosis also, and she has some adhesions in the right side also, and but the right tube is looking healthy. So what you will do now? And I am also confused. I said, okay, I will definitely not going to do salpingotomy for that one, because right tube is healthy, and I am not going to do any treatment right now for endometriosis, because I didn't take consent for the patient that I will remove her adhesions. I didn't take consent for adhesive lysis also. I just take consent for salpingotomy or salpingectomy. Okay, so in this scenario, the right tube is looking healthy. So what I'm going to do, because she has the disease in which in the future might involve her right tube also, and I am going to remove her left tube. And what I will do now? So this is also, now you read the guideline, and I think maybe you will answer for me. I think in my mind I will still go for salpingectomy, because if they write it right tube is healthy looking, whatever the disease she has in the future it might affect her fertility, I will just consult the patient and we will manage her later on. Right now, emergency only, I will do whatever the procedure I take consented for. Otherwise, other things I can just tell her later on. But in this scenario, if I will do salpingotomy also, there is a risk of recurrence also. So anyhow, because in this chart, after that, when I will give you the recalls, the question is like that. Consider salpingotomy as an alternative to salpingectomy for women with risk factor for infertility, such as a contralateral tube damage. So you will do salpingotomy instead of giving salpingectomy for women with risk factors for infertility, such as contralateral tube damage. Now, if she has a risk factor for, if she has contralateral tube is damaged already, then you will go for salpingotomy. Inform women having a salpingotomy that up to 1 in 5 women may need further treatment. This treatment may include methotrexate and or salpingectomy. You do salpingotomy, you tell the patient, because when I open, I have one patient like this. When I open her, I saw her that she has one tube already this embedded in adhesions, and the another tube was bleeding. So what I will do, I will do salpingotomy for her. Okay, so I do salpingotomy, then I have to tell the patient 1 in 5 mean 20%. I will tell her, now there is a 80% chance you will be okay, or still there is a 20% chance that I might need to give you methotrexate, or you might need another laparoscopy or laparotomy, that you might need to do salpingectomy. This much we have to tell the patient, 20% chance of reintervention in salpingotomy. So for women who have a salpingotomy, take serum beta hCG at 7 days after surgery, then again serum beta hCG weekly until a pregnancy test is obtained. Why we are doing like that? Because we need to rule out the persistence of trophoblastic tissue. Okay, so we are doing weekly, even here we are doing weekly. So expectant management after treatment weekly till pregnancy negative. Medical management weekly till the pregnancy test negative, and then salpingotomy weekly till the pregnancy test is obtained. So all the management of ectopic pregnancy, weekly pregnancy test, right? In miscarriage, after 2 weeks. In suspected molar pregnancy, after 3 weeks, right? So advise women who have a salpingectomy that they should take a urine pregnancy test after 3 weeks. So this one, salpingectomy, this is like a pregnancy, and you after 3 weeks, you just want to rule out the ectopic pregnancy in other tube, or you want to rule out the molar pregnancy. That's why you are doing here salpingectomy. After salpingectomy, you are doing after 3 weeks, because now you are not thinking about the persistent trophoblastic tissue. You just want to rule out as a routine. You want to rule out after 3 weeks the molar pregnancy, and you will do after 3 weeks. Advise women to return for further assessment if the test is positive, right? So NT-D, there are guidelines, blood transfusion guidelines by the, I think there is a guideline. I forget this, that this one BCH something BCSH. They have their own guideline, and they are saying that even if it is ectopic pregnancy, even medical management, you have to give the NTD. But these are the old guidelines. Okay, so there was lots of confusion between ectopic pregnancy green top guideline, give NTD for medical management of ectopic pregnancy, and that guidelines for blood transfusion, they are saying give, and the nice guidelines said don't give. Green top guidelines said give. So what to do? This is 2019 nice guideline. They said only for surgical management give, and the other don't give, because they don't have resources, they cannot waste state resources. This is what NHS is following. So don't give, only for surgical. Other, if old books, you will see, don't confuse yourself, because these are from old references. So just don't give. Offer NTD, the dose is 250 international unit, or if you want to give in micrograms, it is 50 micrograms. All RH negative women. Do not offer NTD to women who receive only medical management of ectopic or miscarriage, first trimester miscarriage less than 12 weeks. You don't give, or they have threatened miscarriage, don't give. If they have complete miscarriage, don't give. If they have a pregnancy of unknown location, don't give. Do not do Clahor test for fetal-maternal hemorrhage, because less than 13 weeks, the amount of fetal-maternal hemorrhage is so less that you don't need to do this test. And you offer all anti-prophylaxis to all races. This one, you offer to all races negative women, but do not offer this to women who have received only the medical management, right? So you don't need to give the medical management, you don't need to give NTD, but only the surgical management you have to give. You see here they write, don't give for threatened miscarriage, don't give for complete miscarriage, don't give for medical management or miscarriage, don't give pregnancy of unknown location, and don't do Clahor test. That's it. So the lecture has this lecture. I want to show you another lecture in which. Sorry.
Please ask a question.
Yeah.
We get if there is a pain or repeated bleeding the first trimester.
Sorry, there is a pain or what? Yeah,
we give NTD.
Yeah, it's written in the old guideline. It's written in the green top guideline. If there is a severe pain and heavy bleeding, if it is, I think, more than 11 weeks or around 11 to 12 weeks, it is late first trimester with severe pain and bleeding in late first trimester. If pain and severe bleeding, and within the scenario they give like severe pain and bleeding, then you can give. But this is old guideline, old one. In this nice guideline, they didn't mention those words here. They just mention if there is a miscarriage, if it is all about less than 13 weeks. This guideline is all about less than 13 weeks. Here they said that don't give in miscarriage, don't give in threatened miscarriage, don't give. Less than 13 weeks, don't give. Only give in surgical management. That's it. If they are writing like this, go simple, go, don't confuse yourself. And I don't think so they will give you, because it was written in old and previous guidelines, and in the MCQs book you will find this question, and it's not going to come again. Okay.
Excuse me, ma'am.
Yeah.
Okay.
Yeah, ma'am. Actually, it is written in the BCSH guideline that we have to give NTD prophylaxis to all the women who have ectopic pregnancy or who have molar pregnancies, particularly in the complete mole, when the histopathology is awaited and there is less time. That is, we have to give the NTD within 72 hours. So in all the molars and ectopics, we have to give NTD prophylaxis, even if we have managed them medically or surgically. And in first trimester, if it is significant pain along with the bleeding, then we have to give the NTD prophylaxis, even if there is medical management of a miscarriage or surgical management in the first trimester.
I know. I am talking about the same guideline, blood transfusion guideline, but it is old now. This nice guideline is 2019, and the NHS is following the nice guideline because for the use of their resources, they have to follow the nice guideline, because nice guideline is according to their resources. They cannot give all the patient NTD. Only for surgical management, they said you give, and before also, and NICE didn't change now. This is updated 2012, it was before. And after 2012, the Green Top guideline came 2016. And then they are talking about this one, the same things, okay, like blood transfusion. But the problem is this severe bleeding, the thing that they have severe bleeding, it is in the Green Top guideline. But now it is 2019, this NICE guideline again they updated, and again they said they are persisting in their view that only in surgical management give and all others don't give. If they are persisting in their view, then how come we can select blood transfusion guidelines, and we have to prepare according to the exam, right? So we have to
Yeah.
follow the latest one.
So finally, we don't have to give it in the medical management, but in surgical management, definitely, then we will go for
Yeah,
for
this
giving.
surgical, there is no doubt about it. You have to give, okay? Okay, some confusing point in exam recalls for pregnancy, ectopic pregnancy. Now I will ask you, and then what is how to make it. Okay. So there are some points. They said if patient have vaginal bleeding, or she has pain, or she has declining 48 hours beta HCG. So what you will tell it is a miscarriage or it is a pregnancy of unknown location. Maybe somebody have exam scenarios and they ask in the group that if the patient have this scenario, if you have vaginal bleeding, pregnancy test is decline, beta HCG is declining, and she has some discomfort. So miscarriage or pregnancy of unknown location. So what is your answer? And definitely pregnancy of unknown, they must have given you they must not have given you the ultrasound, right? Or maybe ultrasound there is nothing inside, no gestation sac. So what you think you should select?
Did they mention how much beta HCG is declining?
Yeah, definitely they have given you something like if it is maybe before it was 1000, now the next one is 600, and then the next one is 550. So mostly they are not giving the ultrasound, or maybe they are giving the ultrasound. I think they have given they in the main scenario, because in the EMQ there is a main scenario, and then in the sub scenarios, three or more sub scenarios, they are giving like now this patient, now again, now same patient, now develop this one, now same patient like this, and then they have choices. So what I understand in my exam, it was coming like three beta HCG readings, and it was declining beta HCG. So I will tell you, it is a pregnancy of unknown location, but definitely is a pregnancy, is failing pregnancy, but we don't know. It is until I told you in the NICE guideline, I told you until the first ultrasound cannot confirm, because you don't have previous scan. You need previous scan for diagnosis of miscarriage, right? You have previous scan in which there was intrauterine pregnancy, now patient came with empty uterus, now you can tell it is complete miscarriage. But single ultrasound, so in this scenario there is a broad terminology which is called a pregnancy of unknown location, in which it might be miscarriage, it might be failing pregnancy, because it might be it is a failing pregnancy 100%, but it is maybe a tubal failing pregnancy, or it may be this intrauterine failing pregnancy, and it is a miscarriage, maybe, we don't know, but definitely it's a failing pregnancy, but it is a pregnancy of unknown location, right? It is clear now. It is a broad terminology we will always use when there is a no there is a doubtful diagnosis, right?
Yes, ma'am.
Okay. So if the woman with a decrease in beta HCG greater than 50% after 48 hours, okay. So why I'm writing like this? I think I write like this, maybe something revision. Okay. Okay, this is the question. A 27-year-old woman attend the pregnancy unit, 6 weeks of gestation with lower abdominal pain that settle with analgesia, and she has moderate bleeding. Okay. Now, both examinations show normal, and the pregnancy test is positive. TVS show no intrauterine sac, both ovaries normal. There is no free fluid in the pouch of Douglas. What is the appropriate management? This is a pregnancy of unknown location, right? This is now a pregnancy of unknown location.
Yes, ma'am.
Expected
Ma'am,
management.
beta HCG करवाएंगे.
Which option? A, B, C, D?
Can you repeat the options, ma'am?
Read by yourself. I'm tired now. Read by yourself. There is 4 option now. You cannot see my screen. I cannot.
No.
No,
Your
ma'am, we
screen
can't.
is not shared.
Oh my God, I cannot. Why you didn't tell me you cannot see my screen? You can see or no?
No,
I can
ma'am.
see
No.
immunoprophylaxis, the last slide, not the new one.
Okay. No, I can see stop share. That means it's I can you should see. Okay. You
No,
I'm
I think you didn't start sharing the new one.
okay. It's a diagnosed complete miscarriage and advised to repeat pregnancy test, diagnostic laparoscopy, inpatient admit. Okay, it's outpatient management. You will send the patient home and you will repeat ultrasound 7 days. Definitely 7 to 10 days. We will discuss like this. Patient has pain. No, sorry. Patient has bleeding. No pain. Patient has bleeding. Patient is pregnancy test positive. There is no intrauterine and extrauterine sac. It is pregnancy of unknown location. In these type of patient, you send them home and call her after 7 days. But if beta Hg is more than 1500, that's mean you will call her earlier, more than not 7 days earlier.
After 3 days. After 3 days.
No, not 3 days. This is I'm telling you, it is less. You will call her earlier than 7 days, right? It is earlier than 7 days. Otherwise, there is no beta CG written there. I told you beta CG may be 1000, and then I told you it is 650, then I told you it is 550. So that's mean it is less than 1500 beta CG, declining beta CG. So you will call the patient after 7 days, right? Clear or no? Any confusion?
Yes, ma'am.
If you are silent, I feel there is confusion, right? It is clear now.
Yes, clear. Yes.
Yes,
Okay.
ma'am.
Okay. This is some, okay, to diagnose any kind of miscarriage, I need to know the level of her beta HCG. If it is more than 1000 with no intrauterine sac, then this is a miscarriage. I don't know why I am putting like this. Maybe that time I was thinking something. Okay, this is 25 years patient is due to undergo laparoscopic management of her ectopic pregnancy. Whether questioning whether self-injectomy is essential. What are the chances of persistent trophoblast after? So what are the persistent trophoblastic tissue after this one self-injectomy?
Ma'am,
It is
that
15%.
will be 20%.
No, it is salpingectomy. It is not salpingotomy. Salpingotomy, the chances of intervention, either methotrexate or either the salpingectomy is 20%. But the
20%, right?
yes, the
Ah.
chance of persistent trophoblast after salpingotomy, I think it is something around 7%. So yeah, 7%. And after this salpingectomy, it is something around 1%. So after salpingectomy, it is 1 to 2%. This is, I am telling you, I didn't teach you green top guideline, but I am telling you the after salpingotomy it is 7%. So maybe they give you something around 4 to 8%. And after this one salpingectomy, the risk of persistence of trophoblastic tissue is 1 to 2%. Okay. What are the chances of the same question? So same after salpingotomy versus salpingectomy, it is 7 to 1%, because after salpingotomy 7% and after salpingectomy persistent trophoblastic tissue is 1%. Okay, so 33 years old, she is diagnosed with ectopic pregnancy on ultrasound because on ultrasound there was inhomogeneous. Please, the word is inhomogeneous, and in the guideline also there is a possible chance, there is a high probability if there is an inhomogeneous mass. Okay, so it's an inhomogeneous mass measuring 25 millimeter in the right adnexa, no free fluid, beta acidity of 1200, 48 hours after an initial reading of 1500. First it was 1500, now it is 1200. Okay, so management if asymptomatic, what is the management if asymptomatic? The
It is
beta.
tubal.
Hmm?
It is tubal كده. Tubal pregnancy.